Hello and welcome to the Nurse Rosa's Insights podcast. I'm your host, Rosa Hart, and today I'm joined by Dr. David Dornbos III.
Awesome. Thank you very much for having me. It's looking forward to chatting today.
I'm so glad to get to know you. And who are the other two that you're named after?
Yeah, it's I'm David Dornbos III, named after my dad and my grandpa. I'm still very close with both of them, and we were chatting just a little bit ago. But I love to keep the third out there just to kind of always pay homage to them and pay a little bit of respect to them for everything that they gave me over the years.
Well, that is amazing. I love the humility of that too, right? Of remembering where you came from. And so you practice in neurosurgery here in Kentucky. And we met at a stroke conference a while back and have been trying to make time for this for a
Yep.
while. So
Yep.
I'm really glad we made it happen. Um, so I would love to hear some more of your backstory as to how you decided to go into healthcare. Like, was that the family business or was that something new for your family when you got into it?
Very new for my family. I am the first physician out of my family, actually. A lot of my family, my dad included, are scientists, so that is not altogether new. My dad is also a professor, so the whole teaching and academic side of life, I definitely got got that thirst from him. But I'm the
Oh, okay.
first one that really went into medicine at all from my
Well,
family. Honestly, I kind of just fell into it. I was obviously always wanting to find a field where I could make an impact on people's lives. I think you can do that. You don't have to go into medicine to do that. You can do that in a lot of different spaces. You can do that in education. You can do that in as a mechanic. You don't have to go into medicine to significantly influence and enhance people's lives. But I loved the sciences, I loved biology, and I just loved the human anatomy and physiology. So it was really that passion for wanting to find new ways to impact people and really better their lives, combined with just my passions for the sciences in general. And then I love new technology. And that's really kind of what drove me into neurosurgery and then specifically into vascular neurosurgery is it's a very changing, evolving field. The field of neurosurgery is still relatively new. It's not been around that terribly long compared to medicine at
oh,
large. So it's that really the just and because it's so new and because it's such a space, it becomes a very innovative space. So there's a lot of just new technologies, whether it's new applications for AI, whether it's new devices, whole new surgeries or procedures for new pathologies, are it's a constantly changing field. I've been now an attending, meaning done with all my training for almost 5 years. And even in those 5 years, things have changed. We treat aneurysms differently. We've got new pathologies that we treat that we didn't 5 years ago, and just new ways to help people.
but
That's really what sucked me into neurosurgery.
yeah. And so, what are some of the things you treat now that you didn't 5 years ago?
Yeah, probably the biggest one, the most recent one that we started doing is it's a CSF venous fistula embolization. So these are patients that actually have low pressure inside the brain because they're losing spinal fluid through a vein fistula, and they're typically in their mid or their lower back.
Oh, wow.
It's something we've known about for a long time. I think it went underdiagnosed for a very long time, and it just started to become more readily recognized. There were some new imaging techniques that really helped to
Mhm.
see it better so we could pinpoint where it was. Now, historically, the only way to treat that was with an open surgery where you had to make a big incision, drill off some bone, go find where the leak was, and try and take care of it that way. We now can go in once we've found where it is with catheters just through veins, through blood vessels. So single pinprick, and we can go in and seal this thing off from the inside with glue. So it's things like that, things that didn't even exist 5 years ago
Amazing.
that now we're doing relatively regularly. And then there's also it's just even aneurysms we've been treating for a very long time, but there is constant innovation and iteration in the ways that we can treat them. So historically, they were all done with a big open surgery. We still do that from time to time. That still is the right thing for certain people and certain types of aneurysms. But a lot of aneurysms now we can treat again with devices from the inside of the blood vessel. So again, just single needle
Okay.
prick in the wrist, and we can go up and cure these aneurysms without ever having to actually open the patient up.
Yeah, which is much safer, much less invasive. That's
Yep.
amazing.
Yep. Yeah, for sure.
Yeah. And so tell me some more about the other work you're doing in innovation with neurosurgery outside of actually like touching patients.
Yeah. Yeah, it's the so my life is well, as for most physicians, I suppose, spread pretty thin and across
Right.
multiple domains. It's the so here at University of Kentucky, 50% of my time is clinical care. It's seeing patients in the outpatient clinic. It's seeing patients for surgery. It's seeing patients for those endovascular or those minimally invasive procedures. 50% of my time is actually dedicated to research, and that research takes up multiple different pathways. So some of it is looking at ways that we've treated things in the past and trying to identify areas or predictors of ways that we can do it better down the road. The majority of my work is actually in ischemic stroke, where we've basically been able to work with one of our industry partners on the imaging side. It's Siemens is the name of the company.
Mhm.
We built a special CT perfusion platform, which basically allows us to see a real time glimpse of how well the brain is getting blood flow at the exact moment we're taking the picture. And we use it in the setting of a stroke. So in stroke, obviously, there's a blood clot that goes up, it gets lodged, and it's not allowing part of the brain to get enough blood flow. So the CT perfusion scan allows us to see the different areas of the brain and where more blood flow or where less blood flow is occurring. And we can actually see that, and we can actually quantify it now. So we can see specific regions in the brain how poorly they're getting blood flow or how okay they're getting blood flow. And when we're going in there to pull that clot out and remove it, we are grabbing arterial blood samples while we're in there. It's part of the standard nature of the case. But now we can basically take our sample pictures and we can overlay that on that perfusion image. And we can see on that traditional perfusion scan where those blood samples are coming from. And we're using that to help identify new biomarkers and new drug targets to help stroke patients. With these stroke patients, we can get the blood vessels opened about 95% of the time. It's
Yeah.
almost always we can get the blood vessel back open. Now, unfortunately, only about 30 to 40% of those patients end up having a good outcome. Some of that is because there's so much damage that's done before we actually get in there that we can't reverse it. There are also some secondary things that start to occur after we get the blood flow restored that, despite us getting the blood flow opened, patients still continue to get a little bit worse, even though they're getting blood flow again to the brain. And what we're trying to do is really find new ways to help that group of patients where we got blood flow opened. The brain is not damaged when we get it open, but they start getting these secondary effects that accumulate and cause worsened damage kind of in a secondary manner over time. So that's been kind of a big part of what we've been doing in the innovative space as well. And then the third pillar of kind of what kind of keeps me busy and keeps me ticking is a lot of the work that I'm doing with it's the CNS, it's the Congress of Neurological Surgery. It's
Mm.
the biggest neurosurgical society that's out there that exists, and it's one that I've been able and been fortunate to work with for the last couple of years. I started working with them probably about 4 or 5 years ago now, and really I've started getting very invested in it over the last 1 to 2 years. It's a fantastic group of people, very driven to not only improve the lives of our patients, but also the lives of the providers as well. They're very well focused on physician wellness and
Mhm.
just on continuing to drive the field forward, which is what I'm most interested in. It's a strong focus on resident education and new innovation in the neurosurgery space. So within that organization, we're just starting to launch this new program. It's been around actually in part in the past with CNS, but it's the CNS Innovations Institute, and we are actually starting up a new fellowship within that group that will basically take young neurosurgeons, young innovators, people with innovative ideas that
Mhm.
are still just kind of getting it off the ground. Some people that just have a napkin sketch of how they want to change or make this new device. Some people who have a new tech development that's already up and ready and almost ready to go, but they need some help with fundraising and kind of getting it off the ground.
Yeah.
But we're kind of building a platform to help them do that, getting them the education they need, the mentorship they need, and just some of the contacts that they need to actually make this thing a reality. So it's been a lot of fun. It still is very much in evolution as we're kind of building it up. It'll be kind of ready to go live and launch within the next couple of months here, but it's that focus on innovation is really what attracted me to just become more invested and work very closely with the Congress of Neurological Surgery.
That's awesome. And yeah, I think neurosurgeons in general are known for being driven. So
Sure.
that's not a surprise. But, I've met so many brilliant people through this podcast and others who have great ideas. And what really stands out and what I've learned is it's not that innovators necessarily are the only ones who have ideas, but they're the ones who are taking action on it.
Mhm.
And what else are surgeons known for but taking action on something that other people would maybe hesitate to do, and you just can't afford to hesitate
Yeah,
when someone needs an intervention like that. Like in a stroke, time is brain and every minute counts. So I love this combination. And so it's really exciting to hear because it's not a group I'm following, but maybe I'll have to now, especially because you said you've been doing a podcast, right?
yeah. Yeah, we've done a series of podcasts. I would definitely check it out. It's the CNS has its own podcast channel that you can subscribe to, and you'll get them
Mhm.
as they come through. The ones I've been most involved with, the podcasts I've been most involved with, have been the ones focused on innovations. But we have other podcasts on education, on leadership, on all kinds of different ventures within the the innovations ones that I've been involved with in the past have actually highlighted some of the kind of key thought leaders in the neurosurgery space that are
Yes.
innovating actively and are talking
Mhm.
about we've talked about all kinds of things on there. We've talked about how they got their idea in the first place, how they've been able to develop it into either a pre-commercial or a commercialized reality, and a lot of the way, the lessons learned along the way, the things they wish they did do, the things they wish they never did, and really just kind of getting those insights, I think is
Yeah.
very helpful. It's
Right?
yeah, no, good group.
You definitely need to learn from other people what not to do so you don't have to repeat those mistakes.
Yeah, yeah, that's often some of the most valuable places to learn.
Right? Exactly. So I guess this brings us to the $1 billion question that I ask every guest on the Nurse Rose's Insights podcast. Are you ready?
I'm ready.
Okay. If you were given a grant for $1 billion, and before we started on this, you showed me your whiteboard where you have all of your grant information
Mhm.
written. So I know you actually think about this more than most people. But if you were given a grant for $1 billion that you could decide where it goes and you wanted to use it to meet a need that you see in healthcare, how would you like to see it used strategically to have the most sustainable impact?
Yeah. No, the I like that question a lot. Obviously, it's helpful. $1 billion is a lot of money. So I am going to cheat and use it in multiple domains, but I'll kind of focus towards the same end goal.
And as long as they have sustainable impact, I guess that'll be okay.
All right, deal. Great. All right, good. I got permission to cheat with the system a little bit. It's no the it's so my research and a lot of the innovation that I'm heavily involved with, whether it's finding new drug targets or working with different industry partners to develop better catheter systems, better imaging systems. Most of my work revolves around ischemic stroke and
Mhm.
thrombectomy and how we can really help that particular patient population. Stroke is the leading cause of combined death and disability in the United States. It's a massive population of people that get affected by this every year, and it has a very significant socioeconomic impact
Yeah.
on the US, not only in terms of just the cost of taking care of patients, both during and in the aftermath of the stroke, but also just the years lost of people from the workforce. I mean, a lot of these people are still young enough that they could and would otherwise be working. And it's the socioeconomic impact is just can't be understated how much it affects us all, whether you get whether you have a stroke or whether you don't. The so with $1 billion, I think it's really actually revamping, not revamping, just adding to our current systems of care for ischemic stroke. And honestly, that's going to start with awareness is just a huge part. And that's something that we've done a reasonably good job of over the last 10 years or so is really kind of fixing and modifying some of the messaging around stroke where it's obviously everybody knows if you're having a heart attack, you're having that crushing chest pain, you have to get to the hospital right away. It's a very emergent thing. With stroke, there's it's symptoms are not as always clear cut. The Sometimes people can get symptoms that are a little bit vague. My arm feels a little bit heavy, but it's maybe I just slept on it funny. Things like that, where
Or
they tend
especially
to,
women, like, women will have generalized weakness or generalized
yeah,
confusion. It's not as vocal
yep.
as men's symptoms.
Yeah, absolutely. I think getting a lot of those types of educational efforts out into the community is massively helpful just to get people to the hospital quicker. Like I said, we get 90% of these blood vessels open. A lot of the patients, but only about 30% of people have a good functional outcome when they're done. A lot of that is just due to the fact that there's a lot of injury that's already a lot of irreversible injury that's already set by the time the patients get to the hospital. So that time to get there is critically important.
Yeah.
So and getting a lot of the messaging out there, the advertisements, just kind of getting that out into the news and to the general public would be expensive, but it's something that would absolutely be needed. So I definitely take a chunk of my $1 billion, use it for that. And then thinking about systems of care, the and access to care is another huge component that needs work still. Again, it's gotten a lot better. We have here at the University of Kentucky Justin Frazier is my senior partner, but he used actually an AI platform. It's called Viz AI to
Mhm.
build a now north of 40 spoke hospital referral pattern where all of these hospital systems are part of a unified AI network that's working to identify patients that have a large vessel occlusion or a big blood clot that's sitting in an artery that's stopping or impeding blood flow from getting to where it needs to be. Now, those patients very much benefit from getting a procedure called thrombectomy, where we go in with catheters and we pull that blood clot out. Identifying those patients early and immediately and getting them transferred to a higher level of care hospital that has those capabilities is massively important. And depending on where that large vessel occlusion is identified, if you're not part of an AI network, we have good data now that shows that being part of an AI network like that, it doesn't necessarily have to be the one that we use, but using an AI type of a network saves on average between 20 and 45 minutes to get
Whoa,
patients transferred somewhere. Yeah, and it's
that's
the
a lot
we
of
kind
brain
of
cells.
is a lot of brain cells. It's we always talk about how time is brain.
Mhm.
There's a paper that's kind of old now, but it was pretty well done. But we know that every minute that you have an occlusion, you're losing around 1 million neurons. So having a delay of 20 to
I think
45 minutes is a massive,
may I
massive
just
difference.
emphasize your point, like, it's 1.9 billion, I
Yeah.
think?
Yeah. Yeah, yeah, no, I think you're right.
Yeah,
You lose a lot of neurons per minute. So every minute matters and every 45-minute chunk of time matters a lot, in terms
yeah,
of how patients will do. So that would be probably pillar number 2 of my $1 billion plan is really just kind of getting that type of infrastructure more widespread throughout the country. We're very much benefited here in Central Kentucky to have that big referral network to get those patients
yeah,
identified quicker, to get them through the process quicker. And then again, it goes down to stuff that seems that I think a lot of us, myself included, take for granted, but just the availability of EMS. There are not enough EMS providers out there. The ones that we work with are fantastic, but there's not enough of them. So there's
yeah.
frequently times where we identify somebody who needs to come to us emergently for this
Yeah.
procedure, and we can't get them to us emergently because there's just not enough resources out there. So I think getting a lot of those resources, especially to the rural communities and to the places that don't have a lot of resources immediately available, would be another place where you can make a massive impact and a massive dent. And then once the patient gets up here, like I said, from a procedural standpoint, I probably would not invest a ton of money into that. We've gotten very good at getting these
Right.
clots out very quickly.
Like,
That's
get
just
them
because,
faster and they'll do better.
yeah, exactly. Yes. And yeah, now it's less to do with how do we fix the procedure to make the procedure faster. There's been a lot of companies, good companies, that
Mhm.
have worked really hard to get better catheters and just better developed and more iterative catheters to really cut down on those thrombectomy times, the speed at which we like start procedure to end procedure. We can sometimes a lot of times now do that in less than 10 minutes. Like we can get in and
Yeah.
get out like very, very quickly. It's more kind of getting the patient from you have symptoms to that table, shortening that duration is really where I think you get most of the bang for your buck in terms of the $1 billion plan. And then I think another big investment is, and I'm definitely biased because this is where my research is. So I definitely would like to sequester some of that money for this part, but
Mhm.
there are a lot of patients where we get the blood vessels opened and the brain tissue is still reasonably healthy. But as you get the blood vessel open and you get blood flow that starts coming back in, there are a lot of secondary problems. There's inflammation, there's secondary blood clots that form, there's actually the blood brain barrier, which keeps the blood in the blood vessels and not spilling into the brain, starts to break down. So you run the risk of having hemorrhages afterwards. Finding new ways to offset that secondary injury that people get after the stroke, again, would just I think do a ton of very beneficial work for these patients.
That does sound very comprehensive. And I do want to also encourage you that I think a lot of that messaging part, people think it would be really expensive. But as I've been doing more as an influencer and things with earned media as a
Mhm.
podcaster, I've realized there's a lot of room for what they call earned media, which is free opportunities to be on TV and the radio and reach mainstream audiences. And I guess it is mostly, older audiences who are technically more likely to have a stroke who are going to
Yeah.
be watching traditional TV or radio. So I think that is actually something we could tangibly do if
Mhm.
the time was allotted to doing it strategically. So if
Yep.
anyone wants to sponsor my life to just do that all day, every day, I would be willing to do that or find the best ways to do it. And as for the rest of it, like, thank you so much for highlighting the importance of investing in our EMS infrastructure because, like, right now, at least in Kentucky, it's run county by county and it's all under the Department of Transportation, not even the Department of Health. So there's just a lot of breakdown in not standardization, I would say, and support.
Mhm.
Like one county might have dramatically better resources than the next county
Yeah.
over. Nobody has too much, but
Yeah. That is true. Yeah. It is amazing how much it changes county to county. And it's I mean, I get to know our EMS providers reasonably well, and they're all like, I love them. They're just fantastic people. But they're just stretched thin. Like they only have so many ambulances. They only have so many helicopters per county, and they're also making triage decisions based on what they
right.
have available to them. So I definitely get it, but that would be absolutely a place to invest some resources and get a massive bang for your buck.
It might take taking that money towards, like, lobbying efforts to get them better reimbursement from, like,
Yeah.
I don't know, Medicare, Medicaid, like, the CMS reimbursements for those runs. Because right now, they don't get reimbursed enough to justify the run.
Yeah.
So, that's just not a sustainable way to keep going. So, I think that would
Yeah.
definitely make it sustainable if they could just get reimbursed appropriately, like, adjusted for inflation,
Yeah.
which it
Yeah.
just has been in forever for
Yep.
one thing.
Yep. Yeah, no, that's another thing you take for granted is the fact that it's obviously
Mhm.
inflation even in good times, continues to occur. And yeah, unfortunately, the dollars towards given towards medical providers, whether it's physicians, nurses, hospitals, EMS, has gone down. Hasn't even stayed stable, much less
Right,
like
it's
kept up with
actually gone.
inflation. It's gone the other direction. So yeah, that direction is it's not the best, but we're obviously continuing to lobby and work on that as best we can. But it's yeah, no, you're 100% correct there.
Yeah, exactly. It is so great to touch base with a kindred spirit on all of these stroke related issues and innovations. And so, if someone wants to find your podcast with CNS, what is the name of it? Is it the CNS podcast or what's
Yep.
it called?
Yep. Yeah, it's
Mhm.
the CNS podcast. If you look it up under either just CNS or Congress of Neurological Surgery, it gets you to the same place.
If you're feeling froggy and you want to spell all that out.
Yeah, yeah. If you want to, if you just use CNS, it'll get you there.
Yeah, I will link it in the show notes so somebody who's
Awesome.
listening can just tap on it. But and then if anyone wants to reach out to you to talk about this some more, is LinkedIn the best way, or do you prefer X, or what's your preferred way?
But LinkedIn is what I use most frequently.
Okay,
It's the I actually just recently started using it, and I love that platform. It's really
right.
nice. It's the so that's probably the easiest way to get a hold of me. But yeah, absolutely, that works very well.
Fantastic. Awesome. And then are there any other places that you put stuff that you would like people to follow that I didn't ask you about?
Yeah, it's LinkedIn, X, and Instagram are probably the three
Okay.
where I most frequently utilize it. And you'll see a lot of things from me regarding UK, regarding our research, and regarding the Congress of Neurological Surgery. So you'll get all three.
Perfect. I will link all those in the show notes. And then for our listeners, if you like this episode and you want to see what's up next, make sure you like and subscribe wherever you are listening, or if you're watching on YouTube, please leave me a comment and let me know what you thought. Like, do you think we need to spend the $1 billion this way, or do you have a better idea? Because I want to hear the best ideas. So let me know. And I will see you in the next episode.